Welcome to My Dental Key and International Implant Institute's video covering socket grafting. In this video, we'll provide an overview of socket grafting, including the importance of the procedure, bone formation process, and various materials used. As an overview, socket grafting follows atraumatic extraction and starts with preparing the extraction site by removing granulation tissue, irrigating the socket, and filling it with graft material. A membrane is then placed over the site, and sutures are used to secure it and promote healing. Socket grafting ensures the extraction socket heals with adequate bone levels and without deformities. While the site can heal naturally, grafting promotes optimal bone quality and thickness, making it particularly important for sites intended for future implant placement. This is important because the alveolar ridge, the ridge of bone that supports the roots of teeth, becomes susceptible to resorption after extraction due to lack of functional pressure in the area. This resorption can cause the remaining teeth to shift, alter the patient's bite, and reduce the vertical dimension of occlusion, negatively impacting both the patient's aesthetics and function. Socket grafting helps maintain bone volume, prepare the extraction site for future implants, and improve overall restorative and aesthetic outcomes. After atraumatic extraction, copious irrigation helps to reduce the microbial burden through removing tissue debris, metabolic waste, and tissue exudate. This ultimately helps to promote healing. Before we explore the materials used in socket grafting, we'll first review key bone remodeling terms. These key terms are osteogenesis, osteoinduction, and osteoconduction. Osteogenesis refers to the ability of a material to directly form bone tissue. Materials that are osteogenic contain viable bone stem cells, also known as osteoprogenitor cells, or differentiated and matured bone-forming cells called osteoblasts. Osteoinduction refers to the process of initiating osteogenesis. Specifically, it involves the material's ability to stimulate osteoprogenitor cells to differentiate into osteoblasts. This is done through growth factors that are associated with bone formation, such as bone morphogenetic proteins, platelet-derived growth factors, transforming growth factors, and fibroblast growth factors. Lastly, osteoconduction refers to the ability of the grafting material to promote the growth of the host cell through generating a scaffold. Osteoconductive materials have a great biocompatibility and promote more osteoblasts and osteoprogenitor cells to migrate to the target site. Socket grafting utilizes bone graft materials which are derived from a variety of sources, including natural sources derived from the patient, cadavers, bovine, or porcine, as well as synthetic sources. The choice of a given bone grafting material depends on multiple factors, including the future plans for the socket grafted site. Let's briefly review each category of graft material. A graft taken from the patient's own bone is called an autograft. Autografts have an osteogenic potential and eliminate the risk of immunogenicity since the material is derived from the patient's own body. They are also osteoconductive and osteoinductive. One approach is to use the bone collected from the flute of the burr used during the extraction process. However, autogenous bone is limited, and obtaining it may require the creation of an additional surgical site, such as the ramus, symphysis, or tibia, which can increase the complexity and morbidity of the procedure. Allografts are sourced from the human bone and are usually obtained from cadavers. They are available in demineralized or mineralized forms. They primarily promote osteoconduction, but also exhibit some osteoinduction. Allografts are widely used because of both their availability and compatibility. They are processed using ethanol to remove the soft tissue and cells and then sterilized using gamma irradiation. This process eliminates the material's antigenic properties, reducing the risk of immunogenicity. The sterilization process also affects the biologic properties of the graft and limits its osteogenic potential. Animal-derived bone grafts are referred to as xenografts. They are typically sourced from bovine or porcine bone. These grafts undergo chemical or heat processing to remove organic components, leaving behind a clean, mineralized matrix. While bovine grafts are structurally similar to human bone, they give less consistent results than autografts or allografts due to histocompatibility differences. While xenografts are osteoconductive, they lack osteoinductive properties and still carry a potential risk of immunogenicity. Synthetic bone grafts, or alloplasts, are made from biocompatible materials such as hydroxyapatite, calcium phosphate, or bioactive glass. These materials are made to mimic the mineral composition of bone. Alloplasts eliminate the risk, however small, of disease transmission, making them a great option for patients who require a safe and predictable bone graft. They also have the slowest turnover rate and are therefore osteoconductive. However, they are not osteogenic or osteoinductive unless proteins are added. It's common to mix alloplast and autograft or xenograft in a 50-50 ratio to combine the strengths of each material. Each graft material offers unique benefits in osteogenesis, osteoconduction, and osteoinduction. By combining these materials and maximizing their strengths, the resulting graft offers the most beneficial outcome for the patient. Barrier membranes are important for holding graft material in place and preventing epithelial and soft tissue cells from migrating into the socket during healing. Since soft tissue heals faster than bone, the membrane acts as a barrier to prevent the formation of fibrous tissue, which can compromise the extraction site. Fibrous tissue lacks the stability required for implant placement, making the membrane critical for ensuring proper bone regeneration. Additionally, barrier membranes protect the socket by preventing bacteria and food particles from entering, creating an environment that allows only bone progenitor cells to migrate into the area and support solid bone formation. Non-resorbable membranes like PTFE are durable and have excellent biocompatibility and mechanical strength, making them ideal for long-term stability. However, they do require a second surgery to remove, which can increase the risk of site morbidity. Resorbable membranes don't require a second removal surgery as they are enzymatically degraded. However, their rapid biodegradation may limit their effectiveness in procedures requiring space maintenance for longer than 1 month. Collagen membranes are a popular choice among resorbable options due to their biocompatibility, ability to promote wound healing, and support for bone growth by encouraging osteoblastic cell migration. Ultimately, when choosing a membrane, whether it's non-resorbable or resorbable, it's important to pick one that breaks down at a rate that matches bone turnover. In this video, we covered the fundamentals of socket grafting, including its significance, the principles of bone remodeling, and the various types of bone graft materials and barrier membranes. Having a clear understanding of these concepts and components will help you successfully select the appropriate materials and techniques for a successful socket grafting procedure. Thanks for learning with us.